right? If I see something, you can have what's called stimulus bound. So I see this magazine. Oh, I'm sorry, I was right in the middle of talking. I shouldn't look at that, right? But I see it, I'm going to look at it. Oh, is that yours? Oh, right, so you see it, you go for it, right? There's this missing boundary between what you can touch, what you can do. That's called stimulus bound. So you're driven, your frontal lobe is driven by the stimulus. That's why it's stimulus bound. You're bound to the stimulus. So you do, even though you should be, your frontal lobe, your social monitors should inhibit you from doing that. Mm-hmm.
You got to repractice and start.
Absolutely. That's why we use many of those things for absolutely strengths and weaknesses, right? Because you want to distract, right, from anger and aggressive other things. Absolutely. Absolutely.
And then you get out of that room because now that's the room that they don't.
Yeah.
Because of the impulse control.
Right.
To get them to do that. I'm going to tell you how thankful I am because what's it look like? I'm walking away and they're getting exercise with it.
Absolutely, but those are good strategies, right? So that's why I tell my clients their strengths and weaknesses, because we try to minimize the weaknesses, but sometimes weaknesses are strengths, right? That can get you out of a more stressful weakness, right? So I would rather use distraction than aggression, right? So sometimes I tell people sometimes your weaknesses are actually your strengths. And how can we use the way that your brain works to help you do the best you can in life, okay? So that's the goal, using your brain to do the best you can, not as an excuse to get away with everything. It's an explanation, not an excuse, okay? Right, this is a biggie. Poor grasp of cause and effect. I have, that's lifelong, kids. I'm sorry to tell you, that's a bad one. Inability to delay gratification, right? Integration of attention. We're going to talk about different aspects of attention and memory that are affected. Okay. Here's our lovely brain. So they can have, these are all frontal lobe or executive dysfunction characteristics, poor organization, planning, difficulty employing strategy use when it's needed. Right? Again, this is that discrepancy between they can repeat factual information. This is what's similar to autism. But in autism, they can eventually get the skill and apply it, but they have trouble with generalization. And FASD, it's kind of a hit or miss, whether they can access the strategy and then apply it when needed in the right situation and in the right way. Right? So employment and use of strategies even learned can be very difficult in fetal alcohol spectrum individuals. Poor judgment, again, this inability to apply known information, right, to new situations or even recurrent situations, okay? They have lots of difficulty forming associations and understanding abstract concepts and consequences of their own behavior, right? Very much so pointing the finger at other people instead of seeing themselves from their own perspective. Very difficult, okay? A lot of the ADHD stuff, but I'm going to talk about differences in that in a little bit. Verbal learning and memory. So we know that alcohol affects the frontal lobe and the cerebellum, so it has a direct impact on affecting an individual's ability to learn and store new information. The hippocampus is affected directly by alcohol, and recall and pulling up of learned verbal information. Okay? They tend to learn fewer words on learning trials. It takes them longer to get, and they get fewer even with repetition. And they have greater difficulty recalling them after a delay. Even recognition trials, even when I give them a clue, this is on the list, they still have trouble discriminating. So they do show impairment in verbal learning and memory. These differences are shown in children with and without physical features of fetal alcohol spectrum, fetal alcohol syndrome. Findings replicated across studies in children and adults, including a study of light to moderate levels of alcohol exposure. Okay, and then again, tying this, the important thing, tying this to functioning and adaptive functioning. Okay, story memory, so we can use a list of words that's kind of random words versus a story. So when it has a context, this is so important when you get testing for FASD. You need a list learning and visual memory and a story. Why is the story important? Anybody? The story pulls for something specifically. No, it pulls for confabulation. Individuals with fetal alcohol or alcohol exposure will be more likely to confabulate in recalling a story than a list. They can on a list also, but sometimes the neuropsychologists miss it on a list, and they call them intrusion errors instead of confabulation. But in a story, it pulls more for confabulation. Very, very important to document because there's huge life consequences from confabulation. If you can say they have neuropsych, they have brain confabulation, then you have an explanation.
And he was coming home from the kindergarten every day when he was home. Well, it's when he because he's got some visual issues with fetal alcohol, he thought he was he. The teachers talk about everybody being he because they don't use names. Yeah. So every time he heard he, even if he wasn't there, he put himself as he and came home and told on himself.
And we're going to talk about something called high suggestibility. Will confess to crimes they have not done. This is absolutely true. As adults, individuals with fetal alcohol are more likely to confess to crimes they have not committed. Okay? And they also are very high in compliance and suggestibility, which, again, I can measure neuropsych and give numbers for that. So very, very relevant and important to consider. Okay? Nonverbal learning and memory. So we know verbal, right? Which, unfortunately, verbal memory has a greater impact on our life because everything is in words, right? So we rarely have to memorize a map or how to get somewhere. We do need directions if we drive, but mostly verbal memory has a greater impact on day-to-day living. Grocery shopping, school, contracts, reading, right? We rely on words. So documentation of any deficits in verbal memory is very important for fetal alcohol spectrum because it has great relevance to activities of daily living and functioning, okay? But also, we need to look at nonverbal or visual spatial memory, okay? So children with prenatal alcohol exposure can display learning and recall deficits and slower rate of learning in nonverbal domain as well as the verbal domain, okay? Again, because there tends to be more global impairment of alcohol in brains than just focal, okay? We're not for sure from the research, though, if retention, if their ability to store visual information is impaired. So their learning is slower in nonverbal, just like it is in verbal, but we don't know for sure that is out on retention of visual spatial information. Research results, depending on the design of the study, is showing mixed results and deficits on object recall. And they use different things like common objects or faces, but we know now that facial memory is measuring a very different part of the brain than memory centers, because facial recognition is in a very specific part of the brain, and we know that from a lot of research in autism. So that doesn't really answer the question of visual spatial memory so much as spatial memory. So that's a very different domain than spatial memory. Impaired visual construction, also very important, and it's mediated by the right frontal lobe, often affected by exposure to alcohol, and can show documentation of confabulation in the visual domain as well. So visual construction, like with the copy of the right figure, very useful. Mm-hmm.
One of the things that's been overlooked in fetal alcohol is some of the eye abnormalities and CDIs and optic nerve hypoplasias and all of this new what in the like the brain not connecting to the eyes and things like that.
Right.
And
yeah, we can't really assess. I have picked up on when you do testing visual scanning deficits, so you can see the CAS and tracking deficits, and then I refer. Yeah. Yeah. Yep. So like the visual construction or trail making where they have to do visual search connection tasks, you can see tracking or saccades are off, and then I would refer for a visual evaluation. Yep. Yeah. Because it's not in traditional, it has to be referred out. It's not traditionally under test that I can give. Yeah. Oh yeah, it's just recently, but just in the last, I would say 5 years that I've been aware of visual deficits. Yeah. Language, very mixed field neuropsychologically. They typically don't have primary deficits in language impairment, but they can, so it's not the same as where they can, bless you, have a delay in language development like in autism, but they can show comprehension deficits and pragmatics, right? So deficits in the nonverbal interpretation of nonverbal cues, and they can have some individual potential some expressive and receptive language skills. But I typically see language impairments more in the academic realm, where language arts in school. So reading comprehension, spelling is a biggie. So we can often see it in that domain. Writing compositions, as they go through school, those tend to be difficult because it incorporates language as well as frontal lobe functioning of putting together a narrative, coming up with an idea, right? Writing a paragraph or story. You have to have sequential components. They have to make logical sense. So the frontal lobe contributes a lot to that. So you get sort of the combination of executive functioning with language. We see difficulty in FASD in this domain as well. Okay? Right, so difficulty in producing a contextually integrated discourse, right? So tracking over time, logically, episodic, the episodic part of memory, like when in time and sequence did something happen or to who. The frontal lobe regulates that and stores that, not the hippocampus, and that can show impairments with alcohol, actually both in utero and in alcoholic dementia later in life. Okay? Visual spatial abilities. So we know that children with histories of prenatal alcohol exposure show deficits in visual spatial perception and significantly in visual spatial construction. They can also have constructional apraxia so that they can't coordinate, hand-eye coordination to do goal-directed tasks in the nonverbal domain. We know they also have greater difficulty processing local features as opposed to global features. So we have this complex design. Is anybody aware of the Rayo figure? It's a neuropsych test. There's a couple variants. It's a Taylor figure. So they're complex geometric designs. And I give it to you, and it's on the top half of a piece of paper. And I just say, copy this. And then every once in a while, I trade colored pencils on you. So I want to see how you approach it, right? So do you look at it and do you get a gestalt, right? So you see, oh, there's a big square, and then there's details, or do you chunk it up? And is it fragmented, right? So some people start with the global and then work to the details, and some people just start over here and go right, and do all the details, and they miss, right? So you either see the trees and miss the forest, or you see the forest and miss the trees. You know that analogy? Mm-hmm. So the radio is very, very helpful in teasing this apart, and is very crucial in FASD for identifying this, because this then has implications for functioning and adaptive skills. Okay? I'm so taking too much time. Okay, I'm really not going to talk too much. There can be growth in fine motor skills. I'm not going to talk about that. Attention. I'm going to skip that because there's some slides at the end I want to talk about the attention specifically. Academic skills, very important. Mathematics, this is very, very important, is almost always associated with a specific mathematics disorder in fetal alcohol spectrum. It's not just difficulty with memory or learning. They actually have problems in the brain because of focal impairment and their ability to understand numbers conceptually. And numbers represent amount and quantity and what we're doing with math. No, you have to continue to try to teach it, but getting a mathematics disorder evaluation is helpful because it shows where their specific deficits are, but it's often in their brain's ability to understand conceptually what mathematics is and what you're doing. Yeah. Yes, exactly. So then you got to learn, you got to teach a different way, like we use either manipulatives, like here's 5 blocks and here's 5 blocks, so 5 times 5 or 5 times 2 is 10. Yep, yep. Yeah, so structural supports, exactly. Yeah. Yeah, so kind of teasing apart where the deficit is coming from, what brain problem's causing it, exactly. Yes, it is commonly associated with mathematics. Can be, yeah, but it is more, it's not 100%, but it is much more commonly associated mathematics disorder with fetal alcohol spectrum. Yes?
I just want to make a comment, just a general comment. My Amanda, our daughter, super smart mathematics. She is super intelligent. However, her functional, she is just way low, on the spectrum as far as functioning goes.
Can she integrate the math from what she knows in her head and on paper into real life?
She can for physical. She can from baking. So if she takes numbers from baking, multiplying a recipe or what have you, she can do that. But
like manage.
What about budgeting? Money.
I don't do story problems.
I got to see how to figure out what mathematical principle to apply, what needs to be done. That story problem situation. You know, where she has to figure out and apply instead of versus if it's written on paper and she's told what to apply. That would be interesting.
I really
story
think that
problem.
we can, some at point here, get on DVR, because that is another big problem with trying to get help. She's. Can we talk about that?
Yeah, we'll get to it at the end. Yeah. Yeah, we will. Yeah. So great. Thank you for raising it. We'll bring it up again. Yeah. Okay. Now, so I want to spend a little bit of time on this. So social skills, social perception, social problem solving, affect recognition, discrimination, identification, and then what does that mean, right? So it's one thing to look at faces on a paper and say that's a smile, so that's happy, this is a frown, that's sad, but what does that mean in real life? What do emotions mean? How do I express emotions? How do I feel emotions? What do I look, right? So emotional discrimination is often impaired, and then theory of mind. Has anybody heard the concept theory of mind before? Anyway, okay. So theory of mind is really, right, the ability to interpret social situations and ascribing a mental state to oneself and others. So you're sort of evaluating what's happening emotionally to the people that are interacting, right? Within yourself and in reaction to yourself, and then you in reaction to that person, right? So the interaction and the interpretation of interaction. It's also social judgment, so what's appropriate in different settings. It's also cognitive flexibility or inflexibility to adapt to different situations emotionally and behaviorally. It's also, right, the difference between expressing concrete literal interpretations versus understanding more nuanced or conceptual understandings of what's happening and what's appropriate in different, what social norms mean and why we have them. It's also understanding that there are, right, proverbs. What's the meaning of proverbs? That there are generalizations or general lessons to be learned from statements, right? A stitch in time saves 9, right? So you can take that literally. That means if you do 1 stitch before it rips, you don't have to do 9 stitches. But what else does that mean, right? A hen in the hand is better than 5 in the bush. Right, so those have meanings. They're making statements about human nature. So understanding that there's an abstract meaning to specific literal words. That communication, especially with peers, right? Every generation has slang in their own language. What does that mean, right? You have to understand the nuance, not just the word itself, right? Right, when they say terms, I can't even think, I'm so out of touch. I mean, what are the current terms? My bad, right? But they often aren't meaning my bad, right? They're not. They're sort of artificially, superficially taking credit for doing something wrong. I can't think of any. Can anybody think of? No, I'm thinking of like slang words that kids use that don't mean that at all, but they use it to mean, you know, like I guess my age was cool. Weird. The bomb, like the bomb. Oh, fat, yeah, P-H-A-T. If you didn't know that, you know, oh, you're fat, that's cool, you're in. You're like, hey, why are you being mean to me? Right, so terms. Yeah, thick, exactly. So all these terms that if you don't know the context and the social milieu, you have no idea what the person is talking about, right? So all of that is theory of mind. It also includes the ability to take the perspective of another person. Okay, so put yourself in the other person's shoes. Okay, and there can be just right lack of stranger fear. They can be naive, gullible, easily taken advantage of, vulnerable. Right? I want to be your girlfriend. Okay, I'm just going to sex with you and toss you to the side. Oh no, he loves me. No, he doesn't. Right? So understanding the nuances of all that. When are people being sincere and truthful versus when are they not? They tend to prefer younger friends and immature, just like in autism. They have superficial interactions, but they think these people are their friends, and they understand, but they don't. Frequently, unfortunately, inappropriate sexual behaviors because of this discrepancy between cognition and the social and emotional development, which lags behind, but they don't like to think it does. And, of course, puberty doesn't often lag behind, so then you have discrepancy between brain and puberty. So lots of problems, and unfortunately that can also lead to legal problems because they tend to like younger individuals. So if they're 21 or 18 and having sex with somebody under the age of 16, even if it's consensual, right, they're committing crime. So lots of problems in that area are dealt with. Okay, so we know some of the research shows that in matched IQ children in alcohol-exposed group had clinically significant elevated scores on these externalizing social problems, attention problems, aggressive behavior. Okay, only 27% of the controls did, was 90% of alcohol-exposed did, and this is even in light to moderate amounts of alcohol. Okay, so this is a huge problem for FASD that we do not see in other populations like ADHD or autism. Okay, so a lot of these externalizing behaviors. In autism, it's often internally, right? So they do a lot of self-stimming or self-harm, head-banging, self-damaging, but they don't often attack other people. Obviously, there's exceptions to everything, but in general. But they can be labeled a lot of times with conduct problems, right, in adolescence. A lot of impulsivity and doing things without thinking about the consequence, in fact, even being unaware of consequences of their actions. Okay, so elevated rates of ADD, ADHD, so attention deficit hyperactivity, oppositional defiant disorder conduct. Right, I don't use all these extra labels because I think the overriding diagnosis is fetal alcohol spectrum, and then I talk about strengths and weaknesses. Number reports often get just this label, or this label, and miss the overriding picture, which is the overall, which should be fetal alcohol spectrum, because then you're only seeing a piece of the puzzle, and these don't explain the whole puzzle. Yes.
So do you diagnose secondary autism?
I do. Yes, if I think the criteria is enough to make it, I do.
And he wrote a really, because everyone says you can't have both. And
oh, yeah, no.
Wrote that he has autism.
Yes.
Secondary, it could be due to genetic dissonance.
Absolutely, I make both diagnoses.
Due to secondary to fetal alcohol spectrum disorder, you can clinically have both.
Yes.
But he fits the criteria for
absolutely.
The childhood disorder of autism.
That is correct. You can also say an individual has Down syndrome and autism. You can diagnose Down syndrome, autism in the presence of known Down syndrome. Absolutely. And ID, absolutely. So absolutely, we are now allowed, and we can now, and oftentimes I'll make the diagnosis of ADHD or an anxiety disorder in the presence of fetal alcohol and or autism, because it's helpful for schools, providers to know that those are primary areas of concern for this individual, even though the reason, right, the overriding reason is the fetal alcohol. Yeah. Right, because they have needs. So when I do all the social testing and they have deficits, absolutely, if they fit that criteria, I'll make that diagnosis comorbidly. Yes. Because you're correct, a lot of people are not aware of that, and that is absolutely allowable.
72% of them met the criteria for autism spectrum disorder, and they said that if you have a child with fetal alcohol spectrum disorder, you should automatically be doing an autism evaluation.
Absolutely, that's part of my FASD.
If you have an autism spectrum disorder, then you can ask the question whether it's related.
Absolutely, I agree with that 100%.
I just came out of Canada.
Yeah. Yeah. Yes, high comorbidity, right? It's the same part of the brain. Fetal alcohol just has a broader range of brain affected than autism, but it includes the whole area that's affected in autism. Yeah.
He actually has that, and then he found a new genetic deletion that's a third connection with brain electrical with autism.
Yes. I know, it's so fascinating. That's why we're making, huge leaps. It's just, if insurance and the government and everybody else could keep up with science, it'd be great, right?
For these people, and they talk on the web and stuff. I just signed up for MAP, and it's for kids. But they also have for adults.
Okay.
And adults have to find them. We can further our own research.
Yeah, very true. So important to do. So important to do. So I want to, we talked about, as we've been going through the clinical and behavioral characteristics, a lot of comorbid diagnoses. Adaptive functioning, obviously, we've talked about. I want to go skip ahead a little bit. This is just a summary of the neurobehavioral profile. These are frequently associated comorbid diagnoses that can be made or often made along with fetal alcohol spectrum disorders. right? They're unfortunately at greater risk for some things. This is so important, right? I don't know if anybody knew that the fetal alcohol spectrum as a diagnosis is more prone to suffering traumatic brain injuries over the course of their life. And we believe that's related to some of the structural and brain abnormalities, that they tend to be clumsier maybe, have poor coordinated movements, but they are at greater risk for suffering traumatic brain injuries, which then can cause worse cognitive and adaptive functioning, greater risk for substance abuse themselves because of prenatal exposure, greater risk for conduct disorder, and then antisocial personality or involvement in the criminal justice system. A lot of physical complications we talked about, I mentioned briefly, and then these other life adversities that affect them disproportionately than other diagnoses, right? We don't often see these things occurring in individuals with autism. Families stay together much more with autism or ADHD. FASD is much more prone to have these other life adversities. That's their risk for. Now, in FASD, there is some research that provides some evidence-based data for neuropsychologists to use in differentiating the attentional deficits from ADHD in fetal alcohol spectrum versus ADHD alone. So there's some 4 domains when we look at a 4-factor model of attention. There's focus, sustain, encode, and shift. And those with ADHD alone have more difficulty specifically with sustaining attention as a primary, a hallmark characteristic of ADHD. Those with fetal alcohol spectrum disorders with attentional problems are more likely to be impaired in encode and shift, okay? So more the executive dysfunction, often have more executive dysfunction than they do in ADHD alone. This is highly relevant because the research shows that individuals it's important because that research specifically indicates that FASD with attentional problems will respond better to dexamphetamine and dextroamphetamine than to methylphenidate variants of stimulants. They don't respond as effectively to all types of stimulants. So knowing ADHD in the context of FASD dictates a different medication treatment for those attentional deficits. They will not respond the same way to all the stimulants as with those with ADHD alone. So it's very, very important to test all aspects of attention and get the whole picture because that dictates treatment. And then obviously, if an individual is given a stimulant that doesn't work for them, that causes rages, aggression, panic attacks, all kinds of agitation, difficulties. Instead of alleviating, that we cause more problems in a person who's already emotionally and behaviorally dysregulated. So very, very important. So there are ways to differentiate that. So that's important to note. I wanted to touch briefly about, I know we're already after 3, can I? So, okay. Thank you. A couple of things I think is important. This is what I mentioned initially. There's some studies. The University of Minnesota got a pilot grant, and they're doing further research as well as San Diego on the use of choline. Has anybody heard of this? Yeah. Choline? So choline is being studied in fetal alcohol. They started in rats, and it was found that when they were exposed to alcohol and then given choline postnatally, so after they had already had the traumatic damage from the alcohol in utero, and then they had developed memory impairments and visual-spatial impairments, giving them choline improved those deficits. Okay, so now they're studying them in children and in humans, and so there's some initial pilot work that's showing benefit of the use of choline, and they're using supplementation with choline in set amounts, and now they're realizing that they're doing it more on a weight-based or milligram per kilogram rate instead of a flat amount for everybody, but they're showing improvement in memory and function in FASD specifically. And now, we know that choline is associated with the vitamin B complex, and it's found naturally in foods like eggs, legumes, beef, and nuts. So having choline in your diet. We also know from some studies that it can be deficient. Choline processing can be deficient in individuals. So treatment intervention, right? We know there's nothing really, no treatment specifically designed for FSD, although we're coming around. So were you really kind of piggybanking on resources that have been used for other groups? Oh, here, I knew I had it somewhere. Dexamphetamine or dextroamphetamine versus methylphenidate. SSRIs or antipsychotics are often used, but you got to try them. It's sort of a hit or miss. given the behavioral and emotional behavioral dysregulation in FAS, those can be used. Whether they work or not is another thing. Cognitive-based and insight-oriented therapies do not work for fetal alcohol spectrum. They just don't retain and apply that information in real life. Behavioral modification works more, and structured support along with teaching strategies works the best. Obviously, they need a group, they need a system. The parent training, social skills training, transitional planning, and some things. Obviously, these are things we've all been talking about. I list some sites here that I think are helpful. I wanted to talk about briefly this idea on the bottom here of assisted decision making. The state of Wisconsin, you know, in the state of Wisconsin, we have, I don't know if anybody's had the unfortunate experience to deal with Chapter 50 or 51, so somebody gets committed, right, involuntary commitment, and then we can apply for, there's different levels of assistance, getting legal assistance in decision making, right? So you can get a doctor's statement or fill out what's called power of attorney for health care or finances. People familiar with those terms? So the power of attorney for finances is if you sign it and the individual signs it, that's giving the other person, the agent, immediately the ability to assist that person with all their financial management. Now, the power of attorney for health care has different criteria. You can fill out power of attorney for health care papers, and everybody should have those, in fact, on hand, but they don't go into effect until they are activated by 2 medical providers. And they have to be signed in your county. So any hospital, like myself, or a pediatrician, a physician, so one can be a neuropsychologist or psychologist, and one can be a physician, or it can be 2 physicians, have to sign that to activate. And that says that cognitively or functionally, this person needs assistance in making healthcare-related decisions. So just filling out the forms for healthcare does not put them into effect. They need to be medically activated. But that does not take away an individual's rights for making decisions. It only gives you, the agent, the ability to make decisions with and for the individual, right? Guardianship is the next legal level where you go to the court and the judge takes away an individual's rights, and now we have to specify that individually for rights, so the right to vote, the right to write a will, the right to get married, the right to get a divorce, to enter into contracts, fishing contracts, driver's license, fishing license, medical decision-making, financial decision-making, placement, educational, vocational. So all of those rights are now listed individually in guardianship papers. And then usually I, as a neuropsychologist doing the eval, I'll pick which ones I think they can do cognitive, which ones they can't. And then the judge ultimately decides whether or not to grant guardianship, and then what is guardianship granted for. And all the rights that are listed are either given to the guardian, and then some may be retained by the individual. But that means the individual no longer retains any of those rights that the guardian has. So the state of Wisconsin is working on a mid-level, something between power of attorney, but gives more help and guidance in making decisions, but that's not full guardianship, because so many people, right, in FSC and autism are getting full guardianship, and the state, you know, too many, right? Yes. Thank you. So assisted decision. So there is a legal situation where you can do assisted decision making. Okay, so that is a legal term and a legal option now in the state of Wisconsin. But there's also this term we use sort of clinically as meaning assisted decision making as a collaborative approach, even if you don't pursue sort of the legal avenue, right? Of working with individuals in our life that have fetal alcohol, helping them to make decisions, so we guide and support and structure that. They make the best decisions for them. So I wanted to just throw that out there. Now, the question of DVR was raised, so I want to touch base. Did you have a specific question about DVR, or just how to get them?
About our experience with DVR.
Okay. Go ahead.
No, I just wanted to bring up the fact that we tried to get her a job. Tried to go through DVR to get her a job. It kills me because she is highly intelligent. I feel like she's wasting, you know, brain. Right. Yeah, that's fine. Yeah, that's fine. Yeah.
So one of the questions asked was about DVR. I think it is very helpful going to DVR because they do some assessment, right? Vocational, obviously Jackie can answer that. But the neuropsychs can be very helpful to tell them, even with IQ, what are their positive strengths and weaknesses, to incorporate that with DVR information to help with placement, because sometimes their expectations of what an individual can do is off. So that, giving them that medical neuropsych piece can be helpful in working with DVR counselors as well. But obviously I'm a neuropsychologist, so that's what I think. But Jackie can tell you whether or not that's actually helpful. Any questions for me? Thoughts? Yes. Yes, so the question is, what is my opinion on neurofeedback? I have to say that that's not an area of expertise of mine, so I want to put that qualifier out there. I've done some research on it, and I have to tell you, at this point, like QEEG and brain-mediated EEG, where they do the electrodes and these studies neurofeedback training, I am not a proponent at this point. I don't think there's enough scientific data that shows that they are actually beneficial. There are certainly some anecdotal studies and individuals that show and reports, and certainly all their sites show studies that show individuals who've responded, and I don't doubt that because there's always some individuals that respond. However, the data that suggests whether or not that's just a placebo effect because you're hoping for anything, and unfortunately at this point, the data to me suggests that it's really taking advantage of people and taking their money when there really are no long-term benefits from that. But I'm waiting. There's some studies going on, and I continue to look for research and stuff on that. Are you aware of any other research or studies I've looked? So that's my current stance. I don't recommend it to my patients. I just don't think for the money that you're getting any bang for that buck. However, not QEEG or neurofeedback. However, I do believe in brain training. So there are some sites like Lumosity and Brain HQ, I think are the two best, and there is data behind that, independent data as well, that shows if the goal is you have to do these brain training or cognitive exercises on the computer at minimum of 4 days a week, I think for like 30 minutes or something, 6 months minimum, and then maintenance. That actually shows, and I've done testing, neuropsych testing, pre and post, and shown significant improvements in deficit areas. So I do believe that can be beneficial in changing cognitive functioning. I don't have all the data yet on whether or not that directly affects functioning. But I have shown change in skill and performance that's been maintained after that was done. So I do advise that, and I don't have any investment or money in that. There's a completely separate centers, but I do give that information to families, and I do refer that because I have seen benefits from that. Mm-hmm. Yes. Yeah. So I was going to say, so another audience member said your son participated in neurofeedback for how long? Oh, wow. Okay. And didn't see any appreciable change? Yeah. Yeah. I'm going to say I have had 2 children that I've worked with that actually got headaches as a result of the neurofeedback. They did ameliorate over time, but they did develop headaches from it. So I don't know if that's a known side effect or not, but yes, thank you for sharing. Any other questions, thoughts? All right.